Welcome to the deep dive. Today, we are taking you right to the bedside into one of the most high-stakes environments you can imagine. We're in the resuscitation bay of a busy UK emergency department during a traumatic arrest. Just picture it's noisy, it's crowded, there's incredible time pressure.
A massive cognitive load.
Exactly.
Yeah.
And you've got this whole multidisciplinary team trying to save a life.
And, in those moments, the spotlight is always on the trauma team leader. Always.
Of course.
But if we're serious about organizational reliability, if we want that essential proactive safety layer, our sources show we actually have to shift our focus completely.
Away from the leader?
In a way, yes. The quality of the outcome, it hinges so critically on the quality of the followership.
Okay, let's unpack this then. Because we're not talking about just, simple compliance, passive obedience.
Not at all, no.
So our mission today is to reframe that follower, not as a subordinate, but as the engaged sentinel. We're going to explore the tools, the CRM protocols that help you mentally rehearse these behaviors before your next shift.
That's it. The target ideal here is what's called the exemplary follower. This person has two core attributes.
Okay.
Independent critical thinking and active engagement. They don't just wait for orders. They're scrutinizing the plan, they're anticipating needs, and crucially, they're offering critiques.
And the research actually bears this out, doesn't it?
It does. Performance metrics show this type of team member has statistically superior job performance. It's not just a nice idea, it's effective.
That reframing, it's a huge shift.
Mm.
So practically speaking, how does this engaged sentinel role actually work in the chaos of a traumatic arrest?
Well, let's use that mental practice.
Yeah.
Imagine the trauma lead is struggling with a difficult surgical airway. They're experiencing what we call cognitive tunneling.
Right. They're completely focused on that one task.
Hyper-focused. And they're missing a critical drop in blood pressure on the monitor.
That's the exact scenario, isn't it?
Yeah.
It's where active followership pays dividends.
It provides the necessary redundancy. If the leader is tunneled, the follower becomes that external safety check.
So they maintain the team's shared situational awareness.
Precisely. They protect the patient from what is essentially a single-point leadership failure.
So what does it take for a team member to step up like that? To challenge a superior who's got that tunnel vision? That requires a lot of maturity.
Oh, absolutely. It demands attributes we normally associate with leadership itself. Flexibility, trustworthiness, and what the sources call a commitment to resilience.
What does that mean in practice?
It means you're willing to admit mistakes, you learn from them, and you actively try to stop them from happening again. You have to stay supportive of the team, but also maintain that high level of critical thought.
It sounds like a difficult balance to strike.
It is, but it gives you the capacity to offer high-quality criticism to anyone, regardless of their rank.
I remember reading about a model for this, Kelly's model, I think. It puts followers on a spectrum.
That's right. So the ideal, the exemplary follower, is high on engagement and high on critical thinking.
And what are the failure modes? The other types?
Well, you have the passive followers, the sheep, who just wait for explicit direction. Then you get the conformist followers. They're highly motivated, but they don't think critically. The yes people.
Right.
And maybe the most frustrating are the alienated followers. They have the critical thinking, they can see the problem, but they don't speak up. They lack the initiative.
So only the exemplary follower can actually step in and function as that safety check.
Exactly. They're the only ones who can.
And this isn't just about patient safety, is it? The sources link this to staff well-being, which is so vital right now in the ED workforce.
It's a huge link. When you empower staff to take that professional ownership, when you actually expect them to provide constructive criticism, the culture shifts.
That helps with burnout.
It does. The research notes a correlation with a decrease in depersonalization, that emotional detachment that's a classic symptom of burnout. So active followership isn't just a safety mandate. It's a resilience and retention strategy.
Okay, but here's the challenge. We can teach people assertion protocols.
Yeah.
But if the culture makes them terrified to use them, they're useless.
They're completely worthless.
So what's the foundational infrastructure you need before you can even talk about these tools?
The foundation is psychological safety, full stop. We define it as a climate of trust, respect, and mutual support, where staff feel safe to speak up, to point out failures without any fear of judgment or retaliation.
And if they do feel that fear?
If they hesitate, even for a second, to voice a concern because of that fear, that hesitation is itself a massive safety issue. It hides essential data.
So the burden for creating this safety really falls on the leadership.
Yeah.
How do they do that? It has to be more than just saying, my door is always open.
Oh, it has to be observable behavior. The sources point to 3 critical things leaders do. First is proactive invitation of input. Don't wait for people to speak up. Proactively ask good questions. Signal that you genuinely want to hear all perspectives, no matter the rank.
So you're setting the norm that not speaking up is the odd thing out.
Exactly. The second behavior is non-punitive accountability. If something goes wrong, trying to improve things through fear, it backfires every single time. It just drives problems underground.
Right.
So incident reporting has to show that the information leads to system improvement, and leaders have to acknowledge the courage it takes to report in the first place.
And the third one, this one feels like it challenges the whole medical hierarchy.
It does. It's deferral to expertise. The culture has to institutionalize this. It means you build a system where the most knowledgeable person in the room on a specific topic is heard.
Regardless of their job title.
Regardless.
Yeah.
Whether it's the senior critical care nurse who knows the infusion pump inside out, or the respiratory therapist with specific airway knowledge, their expertise trumps the senior doctor's rank in that moment.
So the investment has to be in training leadership receptivity before you even get to follower assertion.
You've got it. Without leaders trained to receive a challenge non-defensively, the best protocols in the world will fail.
Okay, that makes perfect sense. So let's move from the why the culture to the how. The specific standardized behaviors. Let's do that mental rehearsal again with our trauma arrest.
Right. The basic building block, the absolute first step, is closed-loop communication, or CLC. It's a mandatory 3-step check for any critical instruction.
Like giving emergency drugs.
Exactly. So step 1, the leader sends a clear instruction. Give 1 gram tranexamic acid the fee now.
And step 2 is for the follower. They have to repeat it back verbatim. 1 gram TXA-4V administering now.
That verbal confirmation is critical. They take ownership, they confirm the dose.
Then the final step, step 3, the leader verifies. Confirmed. 1 gram TXA given. And the loop is closed. No ambiguity.
None. The next tool is for when things are going wrong. It's an escalating tool for advocacy. The CUS assertion technique. It stands for concerned, uncomfortable, and safety issue. It gives the follower clear, standardized language.
Okay, let's rehearse that. You're the follower, the leader sticking with peripheral fluids, but you see the patient's blood pressure is plummeting.
Right. I start with a statement of fact and concern. I am concerned about the patient's rapidly decreasing blood pressure. It's now 50 systolic.
And if that gets ignored?
I escalate. I explain the implications. I am uncomfortable with these vital signs because they strongly suggest developing shock and impending cardiovascular collapse.
And if even that isn't enough, you use the final challenge.
Yes. The signal that forces a cognitive shift in the leader. This is a safety issue. We need to initiate the massive transfusion protocol immediately.
If even that fails, there's a last resort, isn't there? The nuclear option.
There is. It's the 2-challenge rule. This is reserved for high-risk safety breaches where perceptions of risk are just completely different.
So the challenger's job is to state their concern once using CUS, and if it's ignored.
They have to reassert it a second time. That's the 2-challenge.
And what's key here is the leader's mandatory response.
Yeah.
It completely flips the power dynamic.
It does. The leader must immediately acknowledge the concern. And if the challenge indicates a safety breach, whatever they are doing must immediately cease.
Stop the line.
That stop-the-line mandate is the most critical part. It puts the safety protocol above any individual's authority.
So we have the culture, we have the language.
Yeah.
But just knowing this stuff intellectually isn't enough to make you do it in a crisis.
No, it doesn't translate to muscle memory. That's why simulation-based training for these non-technical skills is the only way this works. You need routine practice.
Practice of the social part of it, right? The awkwardness of challenging authority.
Exactly. And the training needs to be recursive. So you cycle through being the leader, the follower, and an observer.
And the sources mention an advanced technique that really stress tests this.
They do. The blindfolded code training exercise.
You actually blindfold the team leader.
You do. It forces them to manage the Resus based only on the explicit verbal information they get from their team. It's all about closed-loop communication.
Wow. So for the follower, that's a total shift. You can't just be a visual assistant.
You become the eyes and the ears. You have to be an assertive, indispensable information provider. You absolutely cannot rely on that dangerous hint and hope technique.
Right, where you just sort of mention something vaguely and hope the leader picks up on it.
It has to be specific, direct, and concise. Decentralized vigilance. That's the goal.
So we run the simulation, we practice the assertion, but the real learning happens in the debrief afterwards.
It's the cornerstone of the whole process.
So how do we make sure that reflection is effective, especially when you're discussing a failure with a senior colleague?
The gold standard method is called advocacy inquiry. It's a structured way to debrief.
How does it work?
The instructor states an objective observation. That's the advocacy bit. And then they ask about the learner's perspective, their rationale. That's the inquiry. It frames the whole thing around systems and perceptions, not blame.
Can you give us some examples, some questions you'd ask after our traumatic arrest sim?
Sure. To get at psychological safety, you might ask, how did it feel when you decided to use that CUS phrase while the team was already mid-procedure?
Okay, that gets at the emotional side of it.
Right. Or to analyze assertiveness, you might ask. I noticed you hesitated after your first challenge. What was going through your mind there? What stopped you from making that second challenge immediately?
Ah, so you're forcing them to analyze their own decision-making under pressure.
And then, to reinforce learning, you ask, what is one simple, meaningful change you'll make next time you feel uncomfortable about a plan? That turns the insight into a concrete action.
So if a hospital system really embraces this culture of the engaged sentinel, how do they know it's working? What's the key metric?
It's a really counterintuitive one. Success, especially in a newly established, psychologically safe environment, is often a measurable increase in reported errors and near misses.
So wait, more reported errors is a good thing.
In this context, yes. It means safety issues are being exposed and reported honestly rather than being hidden by fear. And that is the absolute goal of high reliability.
So what does this all mean for you, the listener? We've redefined active followership here. It's about independent critical thinking and assertive mutual support. It's a vital mechanism for reliability in the ED and, honestly, a powerful strategy against burnout.
And if we connect this to the bigger picture, this whole mandate requires leaders to genuinely institutionalize that deference to expertise, regardless of rank. You now have the cultural understanding and the exact behavioral tools CLC, CUS, the two-challenge rule.
So the final thought is about applying it.
It is. The real question for your next traumatic arrest, as you mentally rehearse these steps, is this. When that patient deteriorates, are you prepared to assert your expertise using CUS, knowing that the leader is mandated to stop the line? Be the sentinel your team needs.
A truly invaluable deep dive into human factors and crisis management. Thank you for guiding us through this material.